So imagine this. What happens when the exact protocol to accurately diagnose a suspected cancer, requires a patient to temporarily abandon the very treatment that is keeping their agonizing symptoms at bay?
Yeah. It's a pretty terrifying scenario.
Right. I mean, today we are looking at a medical journey that is so complex, it honestly just completely shatters the traditional, straight line assembly model of modern healthcare.
It really does.
And you, our listener, you actually handed over this massive stack of sources to us. We're talking the British Society for the Study of Vulval Disease guidelines, the NHS Kernow referral pathways, RCOG curriculum documents, and all these specialist
It was
profiles.
a very thorough stack.
It was. And all of it is driving at one highly specific question, which is what specialist actually treats lichen sclerosus?
And as we were synthesizing all these clinical guidelines, it became glaringly obvious that the answer just isn't a single job title.
Right. It's not like you just go to the lichen sclerosus doctor.
Exactly. Lichen sclerosus kind of forces the medical system to abandon that single issue silo. But to understand why, we really have to look at the baseline reality of the condition, which is established in those BSSED protocols you mentioned.
Okay, let's unpack this. What are we actually dealing with here?
Well, it's a chronic inflammatory dermatosis,
Mm.
but it doesn't just cause localized discomfort. It aggressively alters the local architecture of the body.
Wow.
Yeah, clinicians are tracking this very specific constellation of signs. We're talking hyperkeratosis, ecchymosis, which is like subcutaneous bleeding erosions, and that classic pale figure-of-8 pattern extending across the vulval and perianal regions.
And that comes alongside severe dyspareunia and dysuria, right? So pain with sex and urination.
Precisely. It is intensely painful and disruptive.
So with the intensity of that clinical presentation, it naturally makes you assume the patient is immediately fast-tracked to some rare disease research hospital.
You would think so, yeah.
But the NHS Kernow guidelines, they chart a very different initial course. The absolute first line of defense before any secondary care specialist is even paged sits squarely in primary care.
Right. And that emphasis on robust, immediate management at the general practitioner level, it's really the cornerstone of the uncomplicated LS pathway.
So what does the GP actually do first?
Well, primary care essentially initiates a complete overhaul of the local ecosystem. The baseline protocol mandates stripping away any potential chemical irritants.
So changing out your body wash.
Yeah, introducing soap substitutes,
Yeah.
heavy use of emollients to sort of artificially reinforce the compromised skin barrier. And they might also integrate topical estrogens if, say, vaginal atrophy is compounding the dermatological breakdown.
I mean, pure hydration and barrier protection makes a lot of sense, but an emollient isn't going to halt an aggressive autoimmune response, is it?
No, definitely not. It's
Yeah.
just the baseline. The guidelines quickly escalate to the heavy artillery.
The fire extinguisher.
Exactly. Super potent topical corticosteroids,
Mm.
specifically clobetasol propionate.
Because the underlying mechanism is this unchecked inflammatory cascade within the dermis, right?
Right. So the clobetasol acts as this massive, non-selective dampening blanket on that local immune response.
But wait, applying a super potent steroid to a sensitive area, isn't there a risk of thinning the skin?
Oh, a massive risk, which is why the BSSVD protocol for applying it is meticulously calibrated to avoid inducing further tissue atrophy.
Yeah, I was reading this, and the dosing schedule reads like a forestry manual for managing a controlled burn.
That is a great way to put it.
You have this raging physiological fire, and the GP applies overwhelming force to suppress it, but keeping that maximum force applied indefinitely would just scorch the earth.
Yeah, it would thin the already vulnerable epithelium to a dangerous degree.
So the guidelines dictate this strict mathematical taper to basically bring the boil down to a simmer.
Right. And the metric they use is the fingertip unit. It's calibrated to exactly 0.5 grams of ointment.
Which is tiny.
It is. The protocol initiates with maximum suppression. So that's 0.5 grams applied nightly for 4 uninterrupted weeks.
Okay, so hitting it hard for a month.
Yes. And once the acute cytokine storm is theoretically suppressed, the structural taper begins. The patient shifts to alternate nights for 4 weeks, and then eventually steps down to a maintenance dose of just twice a week.
The sheer precision required from the patient is staggering. I mean, a standard 30-gram tube is supposed to stretch across a solid 12 weeks or even 3 to 4 months.
Yeah, we are talking about microscopic amounts of active ingredient holding back a relentless inflammatory process.
And what defines success in this phase?
The clinical goal here in primary care is strictly symptom management and halting the disease progression.
Just hitting the pause button,
No,
basically.
exactly. The guidelines are entirely transparent about the limitations here. Shipment success is defined by alleviating the severe itch, the pain, the fissuring. But any anatomical resorption or pigment loss that has already occurred prior to initiating the steroid.
That's permanent.
It is permanent, yeah.
Mm.
Globitose cannot rebuild tissue. It merely freezes the current architectural state.
And I feel like that limitation is the exact friction point that propels the patient out of primary care.
Absolutely.
Because if the GP's toolkit is primarily focused on just halting progression, the inevitable question becomes, well, what happens when the anatomy continues to alter or the protocol just outright fails?
Right, and the sources indicate a branching path at this stage. You escalate to a triad of core specialists.
Right, dermatologists, gynecologists, and genitourinary physicians.
Yes, and the decision of which branch to take depends entirely on the predominant clinical manifestation. Dermatologists are, they're the foundational experts in the skin pathology of LS.
Like Dr. Fiona Lewis from the specialist profiles we looked at.
Exactly. Taking Dr. Lewis at Guy's and St. Thomas's as a prime example, her entire medical thesis centered on the clinical and immunological aspects of lichen sclerosus.
Wow.
Yeah, so when the primary challenge is deciphering the cellular mechanism at the dermatoepidermal junction, a dermatologist really leads the charge.
Okay, I have to push back a little on the logic of branching out from there, though.
Oh, how so?
Well, if lichen sclerosus is fundamentally a dermatosis-like, it is a condition of the skin, why are we pulling in OBGYNs at all? Shouldn't the immunology expert just handle the immunological skin condition?
I mean, if the skin existed in a vacuum, yes. But LS predominantly targets a region that is intrinsically tied to complex reproductive, urinary, and sexual functions.
Right, it's an entire ecosystem.
Precisely. And the gynecological profiles in your sources, like Dr. Farzana Khan and Dr. Christina Santos, they demonstrate why isolating the skin from the underlying ecosystem just fails the patient.
Because they have that dual background, right?
Yeah, Dr. Khan's background in both dermatology and obstetrics allows her to assess not just the dermal surface, but the corresponding vaginal health, the volume changes, and the deeper tissue integrity.
That makes perfect sense when you consider the interconnected pelvic floor response.
Oh, completely.
Because if a patient is experiencing chronic, severe, nociceptive input like constant tearing and pain at the surface, the pelvic floor musculature is almost certainly going to react.
Yeah, with involuntary guarding and tightening, it's a natural defense mechanism.
And that secondary dysfunction requires gynecological intervention.
Exactly. Dr. Sina's clinical focus targets that specific overlap. Pelvic floor dysfunction alongside gynecological-related bowel and sexual dysfunction. The chronic inflammation at the surface often triggers this whole cascade of functional issues beneath it.
So it's not just a skin problem anymore.
No, not at all. And that triad approach, incorporating GU physicians when there are overlapping genitourinary or mucosal concerns, it ensures the clinician isn't just staring at the hyperkeratosis while completely ignoring the functional collapse of the surrounding anatomy.
But the sources reveal this terrifying threshold where even those highly specialized individual silos just collapse.
Yeah, the late-stage progression.
Right. The RCOG curriculum outlines a stage of LS where the architectural changes become so severe that a single consultant in a standard 30-minute appointment slot is just entirely insufficient.
The structural realities detailed there are profound. I mean, we are looking at aggressive tissue fusion.
Which means what exactly for the patient?
It means the complete resorption of the labia minora, the burying of the clitoris under fused prepuce tissue, which results in really painful clitoral cysts, and severe phimosis.
So the anatomy is literally fusing together.
Yes, the vaginal introitus essentially shrinks and fissures, rendering basic medical examinations, let alone sexual intimacy, physically impossible.
God, that is brutal. And when the anatomy itself begins to merge and flatten like that, the patient is transferred into what the Newcastle Hospital's vulva service describes as a multidisciplinary team, or MDT.
Right. The Avengers Assemble moment.
Exactly. It functions less like a standard medical consultation and way more like a complex architectural restoration project.
That's a great analogy.
You have the gynecologist, the dermatologist, specialist nurses, and importantly, regional plastic surgery teams. All of them reviewing the same blueprint simultaneously.
The inclusion of reconstructive surgeons is so vital here, because you cannot simply excise the fused tissue with a scalpel and expect a functional result.
The skin would just scar back over, right?
Exactly. The RCOG mandates that these specialists understand the mechanics of surgical refashioning procedures. They specifically cite Fenton's procedure and Z-plasty.
The geometry behind a Z-plasty is actually fascinating in this context.
Oh, you looked into the mechanics of it.
Yeah, it's not just about removing a scar, it's about mechanically transposing these triangular flaps of tissue to change the direction of the scar line.
Right, relieving the tension.
Exactly. In a condition where the skin is already under immense inflammatory stress and it's prone to shrinking, relieving that linear tension is literally the only way to prevent the introitus from just scarring right back over after the surgery.
The reconstructive surgeon essentially acts as the structural engineer. They're calculating the vectors of skin tension. And meanwhile, the dermatologist manages the pharmacological suppression to ensure those new skin grafts or flaps aren't immediately attacked by the underlying autoimmune process.
It's an incredibly delicate balance. And the Newcastle MDT model also heavily integrates chronic pain teams, right?
Yes, which is crucial, because after years of sustained inflammation, the central nervous system often undergoes maladaptive plasticity.
Meaning the brain basically rewires itself to expect pain.
Precisely. The pain pathways become permanently amplified, and that evolves into chronic neuropathic pain syndromes, like vulvodynia. So even if the dermatologist successfully suppresses the active inflammatory markers, the patient's brain is still registering catastrophic pain.
Which seamlessly transitions into the psychological mandate within the RCOG curriculum, because managing the somatic pain is really only half the battle.
Right. The curriculum explicitly requires specialists to address the profound psychosexual trauma induced by LS.
Yeah, the mandate to provide psychosexual therapy and advise on the use of vaginal trainers for vaginismus, it really highlights the necessary interplay between cognitive behavioral intervention and physical therapy.
It's a huge undertaking for the patient.
It is. The patient has to slowly, painstakingly retrain their central nervous system and their pelvic floor to accept that penetration or touch won't result in agonizing tissue tearing.
Yeah. The gynecologist repairs the structure, the pain specialist dulls the hyperactive nerves, but the psychosexual therapist has to rebuild the patient's relationship with their own anatomy.
It is the ultimate holistic intervention. I read they even utilize professional medical photography teams to track minute anatomical changes over time.
Yes, which is so important because it allows this massive collaborative team to monitor the surgical and pharmacological progress without subjecting the patient to endless, repetitive physical examinations by 6 different doctors.
Which would be incredibly traumatizing in itself. The sheer scale of that MDT intervention is incredible, but it begs a procedural question.
Okay, what is it?
Well, looking at the NHS pathways, how does the initial GP objectively know when to pull the ripcord?
Ah, right, when to refer them up the chain.
Yeah. If clobetasol halts the disease but doesn't reverse it, how do they measure the line between, acceptable maintenance and treatment failure that requires an MDT?
The NHS Kernow and BSSVD criteria utilize highly systematic, almost mathematical triggers to remove the guesswork from that escalation. It's very structured.
Okay, so what is the first trigger?
The first trigger is diagnostic uncertainty, specifically distinguishing between lichen sclerosus and lichen planus.
Oh, right. The benign vulval skin conditions source outlines the divergence there, right? Lichen planus tends to invade the mucosal surfaces, like the intervaginal architecture or even the oral cavity.
Yes, exactly.
And it presents with violaceous plaques and the classic Wickham stray, which is that fine white reticular patterning.
Right. So if a GP sees a mixed presentation crossing the keratinized skin and the mucosa, they lack the diagnostic clarity to proceed safely. They must trigger a referral.
That makes sense. What's the second trigger?
The second relies on pharmacological math. The guidelines establish a hard threshold for treatment failure.
Okay, hit me with the numbers.
If a patient requires their clobetasol application more than 3 times a week during the maintenance phase, or if they exhaust more than 30 grams of the superpotent steroid in a 6-month window, the frontline protocol has officially failed.
Wow. Okay, so the disease is simply overpowering the primary immunological dampener.
Exactly. Meaning the GP is forced to continuously apply tissue-thinning steroids just to tread water. And that's a dangerous place to be.
Which is precisely when secondary care must step in to deploy second-line therapies, right? Primarily topical calcineurin inhibitors like tacrolimus.
Yes, tacrolimus is the go-to second line.
But how does tacrolimus actually change the pharmacological approach? I mean, if the superpotent steroids aren't enough, are we just throwing an even stronger localized immunosuppressant at the area?
Not exactly. It is less about brute strength and more about precision targeting.
Okay, explain that.
Well, corticosteroids like clobetasol have a broad, sweeping suppressive effect on multiple inflammatory pathways, which is why they carry that risk of widespread tissue atrophy. Calcineurin inhibitors, however, specifically target and inhibit the activation of T cells.
And T cells are the primary drivers of the autoimmune response in LS.
Exactly. So they block the transcription of key pro-inflammatory cytokines without inhibiting collagen synthesis, meaning they don't induce the same irreversible skin thinning.
Ah, so it's a surgical strike versus a broad spectrum suppression.
Beautifully said, yes. But it requires specialist monitoring due to the altered side effect profile.
Which brings us to the third and undoubtedly most critical trigger for specialized escalation, the malignant potential.
Yes, the integration of gynae oncologists into the multidisciplinary clinics is driven by the small but statistically significant risk of squamous cell carcinoma.
And precursor conditions like vulval or penile intraepithelial neoplasia. The BSSVD guidelines are incredibly rigid on this front. Any patient presenting with a persistent ulceration, an unyielding localized sore, or a newly developed induration, which is like a hardened mass within the tissue, that fails to resolve within 4 weeks, triggers an immediate 2-week wait referral pathway.
Yes, for suspected cancer, it completely bypasses the standard queue.
But to definitively rule out malignancy, the specialist has to perform a punch biopsy to analyze the cellular histology, right?
Right. But this introduces the ultimate clinical paradox that you mentioned at the start of the deep dive.
The catch-22. To get an accurate reading from the pathologist, the cellular structure needs to be observed in its natural, unsuppressed state.
Exactly. But if the patient has been religiously adhering to their clobutazole regimen, the steroid effectively masks the true histological picture. It can potentially obscure early dysplastic changes.
So the mandate is clear but brutal. Ideally, the patient must cease the use of all super potent topical steroids for a full 4 weeks prior to the diagnostic biopsy.
It is incredibly tough. The clinician is forced to deliberately withdraw the only effective barrier against the patient's symptoms, allowing the disease to flare, simply to secure a clean diagnostic sample.
4 weeks of unmitigated hyperkeratosis, fissuring, and potential architectural loss, just to prove whether or not the tissue has turned malignant. It is a terrifying reality of the diagnostic process.
It really is.
Yeah.
And it perfectly illustrates why catching the disease early and managing it with pinpoint precision is the only way to protect the patient.
It underscores the absolute necessity of that multidisciplinary safety net. No single practitioner can manage the immunological suppression, monitor the malignant potential, perform complex surgical refashioning, and guide the patient through the resulting psychosexual trauma.
They just can't. It's too much for one person.
So we circle back to the core question you tasked us with at the top of the show. What specialist treats lichen sclerosus?
And the answer is a cascading sequence of specialized care that mirrors the progression of the disease itself.
Right. It initiates with a GP wielding a highly controlled mathematical steroid taper. When the structural integrity fails or the immunological map no longer balances, it branches.
Yeah, to a dermatologist decoding the cellular mechanisms, or a gynecologist managing the functional collapse of the pelvic ecosystem.
And in its most complex forms, it summons an entire architectural restoration team of surgeons, pain specialists, oncologists, and therapists, all analyzing the same shattered blueprint.
The management of lichen sclerosus acts as this massive stress test for the medical establishment. It refuses to respect the artificial boundaries between skin, structure, and mind.
It really does.
And when the gynecologist, the reconstructive surgeon, and the psychosexual therapist are forced to physically share a patient's chart and collaborate in real time, the outcomes dramatically improve.
Which leaves us with an incredibly compelling final thought.
It does. If this profoundly integrated barrier-breaking model is the only way to successfully navigate a complex chronic condition, why isn't this the blueprint for all of modern healthcare?
A brilliant question and a perfect place to end this journey. Sometimes the most effective healing doesn't happen on a straight assembly line, but within a deeply interconnected web of expertise. Thank you for joining us on this deep dive. Keep examining the structures around you, keep pushing for holistic answers, and keep bringing your brilliant sources to the table. We will see you next time.